Hello and welcome to today's webinar, Enabling Consumerism Through People, Process, and Technology, Best Practices for Healthcare Payers. We're very fortunate to have with us today Eugene Cyan, CEO and founder of Softheon, and Jeff Rich, CEO of NFP Health Services Administrators. Welcome, Eugene and Jeff. Thanks for being with us today. Before we get started, though, I'd like to announce a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few days after the call. You will receive an email from me in a few days that will ask if you would like to receive the archive. Please respond to the email if you would, please. And please keep in mind that you may also ask a question at any time during the presentation by typing your question into the chat box located in the lower left-hand corner of your screen, and then click on the Send Message button. At this time, I would like to turn the floor over to Eugene.
Thank you, Laurie. Good afternoon, everybody. And thank you for taking the time to join us today at the AHIP webinar series. Today's topic is Enabling Consumerism Through People, Process, and Technology, Best Practices for Healthcare Payers. We have an hour agenda, and we have divided our webinar into the 5 sections. Let's proceed with the overview of the webinar. We will discuss today in detail part of the consumerism and more so consumer-directed health plans. We will touch upon topics such as HSA and HRAs. We will decipher, analyze, and discuss the best practices necessary to implement this emerging trend in healthcare. We expect the webinar to last 60 minutes, and then we will have a questions and answers session for the audience. Facts and factoids. Before we even proceed, just to clarify what is a fact versus factoids. Factoids are merely some of the predictions as being defined by the leading analyst firms, kind of a forward-looking statements, where the facts we will simply address to historical information that are statistically gathered. So, what are the facts? Well, today, as you may have heard it many times, the topics of consumerism and consumer-directed healthcare topics have been around for some time, dating back to 2005. However, it is ironic given the double-digit growth seen in health savings and health reimbursement accounts, which are tied to consumerism. What you're looking at is a study conducted by Kaiser Permanente in respect to the enrollment covered by workers and by plan types. As you can see the bottom right corner, the significant growth that is experienced in the high-deductible health plans. That is clearly a trend that we would like to get into detail. A high-deductible health plan, just for everyone's background, is HDHP for short, is a health insurance plan with lower premiums and higher deductibles than a traditional health plan. Being covered by an HDHP is also a requirement for having a health savings account. According to Kaiser's survey, as shown above, increasing number of employers have shifted healthcare costs to employees or dropped coverage with rising healthcare costs. As a result, 17% of the privately insured face high deductibles and out-of-pocket costs. Booz Allen Hamilton, another leading consulting firm, expect this number to rise as employees and policymakers grapple with the health costs and outcomes, viewing increased consumer responsibility and engagement in healthcare as an integral part of the solutions in today's healthcare challenges. Another set of facts that we all know that probably it is the topic these days about what's been discussed, the healthcare reform. Clearly, there are many uncertainties given the political climate, but there are also acknowledged facts. In fact, Another study conducted by Kaiser highlights the fact that majority elements of law, except the individual mandates, are all being accepted and is being the direction that in society, plan perspective, are being viewed as. Chief Executive of Kaiser Family Foundation, Drew Altman, notes that the insurance companies may be winning more than they are losing. It is their vision of insurance with more skin in the game that is gradually taking over the marketplace because employers have no other way to control costs. So the shift to health savings accounts, or HSA for short, or the HRAs, the reimbursement accounts, compatible high deductible health plans, has important profit implications for the health insurance industry. These plans have lower premiums and lower aggregate profits than more traditional, fully funded lines. Let's take a look at the HRA adoption. The health risk assessments include questions on medical history, health status, and lifestyle, and is designed to identify the health risks of the person being assessed. As of January 1st, 2011, there are estimated to be 21 million people enrollees in the HRAs and HSAs. AHIP puts the HSA plan enrollment alone at 11.4 million. And the nation's largest HSA/HRA plan is United Health today. United Health has 3.6 million enrollees, followed by WellPoint, 2.5 million, Aetna, 2.3 million, and Cigna, 1.8 million enrollees. It is also estimated to be in the ballpark of $8 billion being accumulated in the health savings accounts as of June of 2011. Let's look at a little bit of the factoid portion of it. This was a presentation made by McKinsey & Company at the past AHIP Institute of 2010. According to McKinsey, there are serious ramifications or changes or tectonic shifts, as they put it. Some of the facts still ties into that. As of since 2000, uninsured rate has been increasing. It is estimated to be anywhere from 36 million to 47 million individuals. Policies to provide coverage to the uninsured could increase enrollment in high deductible and high cost sharing plans, according to McKinsey. For instance, we are seeing initiatives such as high-risk pools to provide health insurance for individuals and small employers who might otherwise be unable to obtain coverage in the market. Many of these policies are community rated and premiums may be 150 to 200% higher than average typical policy. Some states, such as Massachusetts, requires mandatory health insurance where employers require to pay to play, meaning either provide coverage or pay into a fund. All these changes will make payers' business and model quite different than we have today, as suggested by McKinsey. We will see changes around aim at bending the cost curve, perhaps assuming and managing risk rather than underwriting, sometimes perhaps avoiding. Engaging with customers through multiple channels, directly, brokers, public and private exchanges. Developing, configuring, and managing innovative products. And finally, data and rules-driven processes, not just transactional. If we all summed it all up, whether these things will take part as part of healthcare reform, pretty much that captures the main drivers of consumerism. So we strongly believe that these trends will take place, whether the reform should take place or repealed. So what is consumerism? Again, the term has been around for quite some time. This is not something new. And there are many, many different definitions for today's webinar. Perhaps we are rightfully or so. Consumerism viewed as often limited to account-based HSA, HRAs, or consumer-directed health plans, where the consumers are considered to have a skin in the game. It is about empowering individuals with information and financial stake in their own health and healthcare. Therefore, one key feature of healthcare consumerism is providing individuals with opportunities to be financially rewarded for doing the right activities that improve their health. There is much debate over consumer-directed health care. Are HSA and HRA simply a way of shifting costs to member, or do these plans really improve the market for healthcare services by driving people to search for the best care at the lowest cost? We believe consumer-directed health care is more than shifting health costs onto members. It is a way to put consumers in charge of their health care and providing them with the tools to make educated decisions. An expanded view of consumerism perhaps will include focus on health rather than sickness, or preventing diseases before it begins, and helping employees become good health care consumers independent of the plan they're in. Consumer-directed health care is about creating culture of health. Having said that, we are seeing a unique trend within the utilization of HSA, which is considered to be a part of the consumer-directed health or consumerism. As of June 2011, as I mentioned earlier, they are projected or expected to exceeding numbers of $8 billion are deposited into the HSA accounts. Having said that, 25% of the HSA plan members use the products and services as intended, and another 25% treat it like an IRA account. The 50% or so do not use the plan accordingly or do not take advantage of the product and services. This simply suggests that HSA products need a revision, perhaps an opportunity for health plans to enhance or work with employers, or better yet, educating the consumer about the benefits of HSA. According to Pew Internet Projects, 59% of all adults in the United States look for health information online. Increasingly, patients are moving from searching for disease or treatment information to using the Internet to find quality information on doctors and hospitals. This trend is considerably different than 2003, when only 21% of Internet users reported looking for information on specific doctor and hospitals. Plans, tools, and services. A key feature of healthcare consumerism is providing individuals with opportunities to be financially rewarded for doing the right activities that improve their health. Clinical outcomes. 73% of Americans are considered to be overweight in 2010. 65 million have high blood pressure. 1 out of every three children born in after 2000 will develop diabetes. And 60% of employee absences are considered to be related to depression or stress. These are the statistics shared by John Young of Cigna at his May 2011 presentation on the topic of consumerism and health improvement incentives. Incentives and rewards can include activities such as participation in wellness assessment, game playing, attending a smoking cessation class, compliance with a condition management program like taking medications, diet, exercise, office visits, and the maintenance of a good health characteristics: blood pressure, cholesterol, nicotine use, body mass index. With all these drivers, how do we move from where we are today as a society, as a consumer society, to making healthcare consumerism a universal reality? Let's take a look at the regulations. This will not be just perhaps self-imposed. Private healthcare costs are anticipated to grow over the next decade by approximately 6% per year under current law, which is more than double the expected growth in consumer price index of approximately 2.5% a year. Controlling the growth in these costs will require restructuring and realigning the incentives in the system, according to PricewaterhouseCoopers. PwC previously estimated that structural reforms such as improved wellness and prevention, disease management, value-based payment reform, improvements in health information technology, could mitigate growth in healthcare costs by between 0.5 and 1% per year after an initial investment period. So, as we can see, while the healthcare reform packages take steps in this direction, a major focus of the current legislation is on expanding insurance coverage. These reforms propose to make insurance more widespread by providing new subsidies for the uninsured and those with lower incomes by reforming the health insurance market. And we all know that there are several external drivers. Changing consumer models, web-based customer relationship management, rating, underwriting, membership, and billing supports and capabilities to integrate across a number of internal and external business platforms. Future models shall contain all the elements needed to support the products and services mandated by the government and health exchange environments. Healthcare exchanges. Plans need to prepare for the exchange environment, which requires web-based electronic processing of groups and individuals. Technology. Perhaps this is one of the most important areas that's going to change the way the consumers' healthcare delivered to the consumers. Every healthcare payer today has a web initiative, more and more focusing on B2C, business to consumer, things like mobile strategy, as well as attracting and retaining customers to provide innovative new services and ways to communicate it with members. Consumer models are changing and will be driven to new levels through mobile capabilities. According to the study conducted by Research to Guidance in 2010, by 2015, it is expected to be 500 million smartphone users will be using healthcare apps. 500 million people will be looking to their mobile devices for the guidance and the delivery of their healthcare services. Another technology component in the day of an information where we are being bombarded with, Gartner predicts a new concept called context-aware computing. In fact, by 2015, enterprises delivering consumer-facing applications will use what is referred to as context-enriched services within the context-aware computing, which will impact the mobile customer experience. Context-enriched services will use information about the end user, anticipate that user's immediate needs, and proactively offer more sophisticated, situation-aware, usable functions. With the emergence of these new environments and computing models and new application developments, it is critical that health plans' information model must be flexible. Processes must have enough agility and the ability to federate context information in partnership with other context providers will determine the success or failure of consumerism. Let's focus on some of the business drivers. Again, another very commonly used term, 360-degree view of a consumer. Gaining insights into the consumer behavior, understanding preferences, and arrive at a personalized health plan that leads to lower defection rates, better clinical outcomes, and reduced cost of care. It includes customer-centric information, but not limited to plan enrollments, membership, claim, medical histories, wellness program, rewards and incentives, and call center communications. As if the external challenges were not enough, today's healthcare payers are also challenged by these internal technology silos. As reported by leading Gartner analyst Joanne Galimi, the growth of enterprise systems, namely core system or administration systems or care management, etc., and the use of third-party data sources, electronic health records, e-prescriptions, e-imagings or medical imaging are increasing the amount of data that is available to a healthcare payer faster than it is able to use that data. As a result, payers lack the ability to fuse all the data. They have to get a 360-degree view of their customers. In the age of consumerism, a greater focus needs to be on the integration of that data, not just on its delivery. If healthcare consumerism is going to succeed, the aggregation of data is critical You must be able to create a profile for each employee which requires important lots of data from various sources into your systems and deliver personalized, targeted information and recommendation for small, large groups as well as individual consumers. The reason this is critical because in order for members to become active participants in their care, they need to be connected to the realities they face. As the payers must have the ability to present members with the data, including risk assessments that will motivate and incentivize them making the desired changes. Integrated customer acquisition processing for large and middle market groups via automation, supported end-to-end continuously flowing solution to support critical business operations like customer relationship management, underwriting, rating, proposal generation, plan selection and configuration, enrollment renewal management, billing, and broker commission processes. Integrate customer acquisition processing for a diverse portfolio of markets: small group, large group, individual, direct paid, state-sponsored, Medicare, and other specialty market segments via an automation-supported end-to-end continuously flowing solution to support those same mission-critical internal systems. Providing a single point of entry, data-driven automated feeds, downstream systems capabilities, and all business segments, and compliance with the upcoming healthcare exchange environment in 2014, and built-in quality controls. So what are these technology drivers? Sales and installation processes are highly manual. If you look into the enrollment, underwriting, new business, and the many payer organizations that are still we're seeing that are paper dependent, which makes it difficult to do business with one another or being the error prone. Plans solicit many types of customers and has unique processes and products and the systems established for each, resulting in a great deal of complexity and manual effort. Many key processes are managed using office documents, emails, phone calls, faxes, where process flows may include the elements of an imaging or first-generation technologies, workflow technologies, make the move back and forth via updates and passes to one another, yet they are not still sufficient enough to streamline the business. End-to-end customer acquisition and installation processes to be more responsive to customers and market demands, and more information in providing prospective customers with a full understanding of plan designs for all market segments, including large, middle, small, and state-sponsored plans such as Medicaid, FHP, and CHIP. Disparate automation around small group, but overall utilization of broker portals are less than optimal because not all products available through these broker portals or certain types of business segments and operations and other entities are set up to submit their data in different channels, perhaps mail, perhaps electronic, perhaps emails, or specialized processes. Streamlining and automation is being introduced for state-sponsored plans, and similar opportunities exist for the other market segments. So, what does it need? What is needed to make the transition to a successful consumerism-driven business model? Just like any other enterprise project, it will require people, process, and technology. It is a shift of business, a paradigm shift perhaps, to be more specific. The owners of such effort will be comprehensive of the entire organizations. At the executive level, it is absolutely a must, the presence, commitment, and enforcement of such initiative under the executive leadership teams. The project management. This is a big project. We all know that. a 18 months, 36 months implementations. The old waterfall model, technology acquisition, analysis, implementations are no longer the design patterns. Today's business, today's IT organizations are looking to things like agile computing, being able to get results within 30, 60, 90-day cycles, and being able to learn from those mistakes before they take up on another part of the project. The impact on the business is even greater. The product configurations and benefits, things like rating engines, proposal generations, underwriting, enrollment, billing and payment, broker commissions, as well as product renewal, configurations, and management. You will need a stakeholder in each and every one of these areas for a successful transition to a consumer-driven health plan. Process. We have to think big, and you have to think end-to-end process, including the exception handling. We all know that ideal conditions does not apply to the real world. You will be bound with exceptions. Expect the unexpected. And in order to do that, embrace the business process management platforms. BPM platforms are suited to capture, calculate rates, and submit downstream to appropriate resources, and systems to initiate appropriate actions. Self-reconciliation based on business rules and processes for specific elements. An advanced element of an architecture and the use of services for composition of flows, including service invocation steps and people interaction steps. Business process management suites are the tools devoted to implementing multi-step processing flows. Business process execution language standard is often used to document the design, the flow of the data. Metadata repository or metadatabase is used to manage the proceedings of the business process model at runtime. Some steps of the process are implemented by SOA-style services, a service-oriented architecture. Other steps may require human intervention. The Gartner report, the leading IT analyst firm, that predicts by 2015 more than 66% of new SOA-style applications will be implemented using the BPM technologies. Consumerism. Let's dive into the technology. Service-oriented architecture, SOA for short. In consumerism, SOA, it is necessary to layer on top of a core technologies, for example, business process management, enterprise content management, and activity monitoring system to make it possible to collect and aggregate the business events needed to deliver the desired business insight. We talked extensively about the BPM. Enterprise content management. In today's environment, the tight integration with emails, scanned document, faxes, electronic documents, PDFs, it is absolutely critical to successful implementation of consumerism. And those services must be enabled within the confinement or guidance or management under SOA. Business activity monitoring. Advanced reporting analytics, including self-service dashboard analysis, scorecard, forecast, data warehouse, data mining, combining the business intelligence analytics, integrating the links, statistics, and volumes. Enterprise application integrations, integrating portals, core admin systems, as shown on the right, all the way from the admin systems to the business processes to the unstructured domain, where the data does not necessarily fit into the traditional tables. One of the reasons that's why the business organizations resort to building their own access database tables or building their Lotus exchanges or utilizing email as a workflow protocol or using Excel spreadsheet as a data mining tools. These all has to be integrated into a one common platform. And there are times that you will be able to do that given the underlying technology's capability to interface with. And there are times those systems must be replaced. Key point is leveraging. Leveraging and minimizing the risk associated with moving towards consumerism. And that is the fundamental benefit of SOA platform. Schedule fees and verifications of data exchange operations can be easily classified under enterprise application integration. Being able to pull and push functionality across multiple channels, vendors, and move to other systems in real time and batch. Perhaps experience-rated and community-rating business rules will be a critical part of the BPM platform, and the data mapping capabilities to build illustrations based on instructions for defined and changing business cases. Ability to accept electronic payments and interfaces with accounts receivable, and ability to build business rules to effectively stream data to downstream systems and minimizing the data exceptions and rejections. Service-oriented architecture. As I mentioned earlier, this is a paradigm shift in business, and it requires a paradigm shift in technology. This is a diagram illustrating the benefits of SOA. Upon its implementation, the common framework that makes the next business unit, the next functional area, to be able to leverage that every experience, every practice, every technology has been gained during the prior implementation. It is an iterative approach. It is an agile approach. So therefore, organizations, the payer organization, must adopt the SOA best practices to align with other industries, even learn from it, such as financial services, banking, property and casualty, and life. In fact, at the recent Gartner event that I just personally attended, Hartford has made a presentation about moving to SOA platforms, how they were able to move 600 users, call center staff, to the cloud using the SOA capabilities. Service-oriented architecture is a central theme of most modern software initiatives, although many companies remain skeptical about its ultimate benefits. Agility, reuse, heterogeneous operations are all part of the promise of SOA, and aligning with technology vendor with deep domain expertise in healthcare processes is critical to overcoming these obstacles. Strategic importance of SOA is that healthcare organizations should build the ability to consume internal and external services. In technical terms, we will refer them as web services. Cloud services, software as a service suppliers, and business partners are all strategic enabler for their SOA initiatives. Organizations should also adapt an intelligent business operations SOA style when their goal is to dramatically improve situation awareness and reduce the time required to respond to emerging challenges and opportunities, such as the healthcare reform. Enterprise Content Management, ECM for short. Another very commonly used term, one member, one view, to access to all relevant content. The leading analyst firm, Gartner Research, Robert Booz, distinguished analyst, emphasizes the importance of the member-centric call center in the context of consumerism. Health insurance do not have effective online sales and service functionality for the individual markets, must immediately establish such capabilities to compete in the current market and meet future requirements of exchanges, stated Robert Booz. He continued saying, health insurance exchanges play a key role in health insurance reform. An integrated, unified view of member across the organization enables the payer to respond to members with flexibility and speed. Dynamic case management and enhanced collaboration between users enable payers to respond to changing member requirements in real time. In the context of a content management, a transactional content, a workflow BPM, records management, and e-forms. All these content contained within tends to be static. Processes tend to take a long time, and having large volumes of forms and content demands scalability, lifecycle control, compliance, and dealing with the exceptions. Social content management, as the social networks becoming an important channel in the servicing or reaching out to the consumers. document collaboration, workflow automations, alert, task trackings, browser portal viewing, markups, annotations, and version control. With social net contents, the focus is on the high-value people involved in the project-based and long-running development and delivery of high-value content, and optimizing the processes, interfaces, and objectives that relate to them. Online channel optimizations solution focus on web channel sets of technology, portals, web analytics, XML authors, rich media management, mobile device support, so on and so forth. Web-delivered engagement platforms for a variety of industry-focused solutions is a must. Business activity monitoring. Business activity monitoring, or BAM for short, is the combination of business intelligence, financial, clinical, and consumer data that are needed to control costs, optimize the use, and meet compliance requirements. However, many payers have yet to embark on a use of BAM to understand what happened, why it happened, and what is about to happen. Multiple uncoordinated tactical BAM or business intelligence or analytics implementations have created silos of technology, skills, and processes, leading to inaccurate business analytics and intelligence, which in turn cause significant cost duplications and the lack of true view of customers, cost, and compliance. There is a degree of overlap and the redundancy within the IT portfolio, with different projects, departments, and the line of business, each having chosen its own standard or having more short-sighted tactical purchasing decisions. Let's proceed with some examples of consumerism, in fact, that are quite relevant to today's topics. One of them is exchanges. Softheon is one of the vendors who, in fact, has a deep domain expertise and experience in working in an exchange environment. As part of Massachusetts Commonwealth Connector program, Softheon technology has been embraced around the delivery of customer relationship management, workflow management, document management, knowledge management, interfacing the CSRs, the members, as well as back office administration, including Medicaid Management Information Systems, or more legacy applications such as MA21. We also know that there is the presence of private exchanges who has embraced consumerism. And for that, I'm going to turn over to my good friend Jeff Rich from NFP Health. Jeff?
Thank you, Eugene. Appreciate that. Hello, everybody. My name is Jeff Rich, and I'm the CEO of NFP Health, and we've been operating a private exchange in Massachusetts for 35 or so years, and we're currently covering about 150,000 lives. Just some quick highlights for coloring in the background. We pay commissions right now to about 1,400 brokers a month, and we prepared slightly over 1 million quotes last year in 2010, and we offer 6 different health insurance carriers on our platform. And lastly, we provide coverage for about 30,000 small groups in Massachusetts and Rhode Island. The purchasing, the Massachusetts is really an advanced experiment in the implementation of significant health reform. And as such, the small business market has had to quickly understand how to become more engaged in all aspects of healthcare. Massachusetts has traditionally been an HMO market with pretty low take-up of consumer-directed healthcare and HSA-qualified plans. The combination of the organically expensive market that we have, the tough economy, and the impact of reform with more employer and employee responsibility as well as even higher premium costs has dramatically accelerated the engagement of small employers. The individual market in Massachusetts, as I think everybody knows, has an individual mandate, is guarantee issue, and has merged with the small group market. So they're all part of the same modified community rated risk pool. So as quickly as employers have had to engage and understand the healthcare environment, the individual market followed in lockstep. In order for individuals to properly navigate the market, they need tools and functionality that a very short time ago was totally unavailable to them. Even though individuals have tools available to them now, most of these tools are in a nascent stage. Both the providers of coverage and the individuals who are purchasing the coverage are both in a very early stage of development and engagement. Okay, next slide, please. Just a quick look at some enrollment statistics that we have right now in Massachusetts I think you'll find interesting. This chart shows the uptake in enrollment into plans that have at least a $1,500 deductible or higher. Again, that's spread out among 6 different carriers and well over 100 different plan options, probably closer to 150 different plan options. Approximately 65% of all the groups that you're seeing here, or all the groups that we manage, have a broker, and 35% of them are either self-administered or administered using help from exchange representatives. So approximately half of the enrollment into CDHPs is accomplished through self-service as either new clients or current clients who choose to change carriers. Most of the change in the time frame that you see there, going from about 10% to creeping up to 30% right now, is as a result of the increasing cost of premium, so no shocker there. Also, the change represents a large amount of groups who are going from HMO-style coverage into a high-deductible health plan for the first time. So clearly the trend is such that CDHPs are becoming more prevalent and will continue to do so. Okay, next slide, please. The purchasing avenues are comprised of the traditional health insurance distribution, direct to the consumer, through brokers, and through affiliate groups such as chambers of commerce and associations. All of these distribution arms must be supported by the exchange platform, utilizing tools provided to help them discern the choice of plans that best suits their needs. The new paradigm of CDHPs has to weave into the traditional distribution system. And the marketing and pricing trends over the last few years have been on average in the low double figures, around 12 to 15% year over year. There's been a spread of pricing that has ranged higher for the low deductible or HMO plans and lower for the CDHP style plans. As carriers see better experience in CDHPs, they've been prone to try to attract more clients by offering more stable pricing and typically lower annual renewal increases than the HMO style plans. As the pressure has been increased onto the carriers through the not so subtle method of increased regulation and political pressure to keep rates in check, they have increased their plan and network development in a more aggressive manner. Skinnier networks, different co-payments, and deductibles around prescription drug cards, inpatient and certain outpatient procedures. This has created more complexity, thereby making the purchase and servicing more of a challenge. The development of tools to help consumers and employers keep up with the new designs are slowly being put into production. The tools available through the exchange platform, such as filtering and sorting plan choices, doc finders, financial tools to understand the impact of deductibles and pre-tax savings accounts, live chat to answer questions in real time, online wizards that instruct and ask questions, and instructional video have been added to help, but oftentimes can become overwhelming to the uninitiated. All of the traditional parts of the distribution system need to be supported and need to have access to these tools, but oftentimes in slightly different ways. The communication through the exchange platform to employers needs to take into account where they have been and what they're used to in regard to their comfort level, and then enhance it to be able to provide support for them and their employees. Clearly, communication is key, and most, if not all, employers make the decision to enroll in a CDHP as a result of economics. Then once that decision is made, the next big question is, how does this affect my employees? There needs to be clear communication to all employees pre- and post-enrollment as to how the plan works in a very specific way. Most moves to a CDHP will affect employees differently. There will be issues around keeping a doctor or understanding a pre-tax account such as an HSA or an HRA or a myriad of other things that necessitates more communication in both an electronic and paper format. From the employer standpoint, especially a small employer who does not have an HR department, the responsibility for all these different kinds of communication to employees, in many cases, must be offloaded onto the exchange. The continued success of a CDHP is largely dependent on clear and consistent communication. Employee reaction to the adoption of a CDHP is likely met, and sometimes met, with both skepticism, in other words, they're just looking to pass costs on to me, and trepidation, how am I going to negotiate this new plan and this new world of healthcare consumerism. In order to counteract these initial reactions and heighten the chances for continued success, employers must communicate why they're making the changes. It's important to communicate that the reason for the change is less to do with shifting costs and more to do with encouraging them to take control of their health and ownership of effective consumer decisions. And it's important to continue this communication after the implementation. To achieve buy-in and continued enthusiasm, communication regarding healthcare consumerism should resemble more of a marketing plan as opposed to the typical HR-style campaign. And sufficient lead time should be incorporated into communication efforts to ensure maximum traction. A variety of communication methods should be employed, and key messages should be repeated to ensure sufficient exposure and understanding. Behavioral changes take time and certainly require a consistent and concerted educational effort. The tools that are available to aid employers and employees are many and continue to be developed and refined, become easier to use, and appropriate content, multiple media messaging, and good, easy-to-use tools are necessary. Decision support tools need to focus on the needs of the employer, the employee, and the individual. In a nutshell, they need to help everyone understand better about their health and their health care decisions. A company may decide that employees need a way of estimating total out-of-pocket medical expenses to help choose the health plan that's best for them. A calculator could take into account a family's health care use, the plan designs available to them, and the company's cost-sharing formulas. Armed with this tool, employees might find, for example, that the PPO plan would likely cost them around $1,000 a year, while the HMO would cost them only $750. Employees could then make an informed decision about the value of each plan option. Then a bunch of other questions arise. Where will the tools be located and accessed? Will it reside on your intranet? Will there be sufficient technical and hardware resources to support it? Or do you need a hosted product that can be linked to your intranet? Will users have access from work, from home, or from both? And from which portion of the site will employees navigate to these particular tools? The Internet has enabled creation of a new generation of tools to help employees make these healthcare decisions based on more than per paycheck deductions, and word-of-mouth quality. Increasingly, as healthcare costs continue to rise, employees are being asked to take more responsibility for their healthcare. And that means employees and consumers must be more educated and better informed. And interactive web-based products can help employees select from among the various health plans offered, choose available doctors and hospitals, and ultimately make good treatment decisions.
So I will join Rich in his commentary. We think that healthcare payers must be embracing the concept of consumerism within their organizations and defining and implementing using some of the techniques, technologies, as well as operational business models was described by Rich. At this point, we thank you for your time. And before I turn over back to Laurie, I would like to also inform you of our next AHIP webinar, which will take place on November the 3rd, where we will get into the topic of exchanges in more in-depth conversations, both in, again, people, process, and technology point of view. Thank you very much. Laurie?
Thank you, Eugene and Jeff. At this time, we are going to address some questions that came in during the presentation. But I'd also like to remind everyone to ask a question. Just type your question into the chat box in the lower left-hand corner of your screen and then click on the Send Message button. Our first question that came in is, what specific tools do you see used most often when someone is making a healthcare purchasing decision?
I can answer that, Eugene.
Yes, please.
Selecting a doctor is a hospital, other healthcare facility is often more important than deciding which carrier or which health plan is going to be paying the bills. We see that as the tool that's used most often and most frequently. And with the current economic conditions, people are more apt to take a good, hard look at price over anything else. And oftentimes, with the lowest price comes the skinniest network. And even more complicating is that large big-name carriers will have separate and smaller network plans within their lineup of options. So an employee might think, oh, yeah, my doctor's with that carrier, but it turns out that they're only half right. Sometimes the doctor's with the carrier, but not within the specific plan design. And even more complicating is sometimes when someone has a choice on an exchange platform where they have multiple low-price plans from multiple carriers, and rather than having to check each individual carrier's database, the most convenient way is to enter the doctor and have the platform show them what plans that the doctors participate in. So that's something that we see being used very frequently.
Okay, and the next question is, can you give us some examples of how employees can stay engaged in their health care?
Sure. The two ways that spring to mind are employees enrolling in HSA qualified plans or, HRA plans tend to naturally be more engaged. And the HSA accounts in particular have a positive effect and are gaining favor over the HRA in our neck of the woods, and issues such as portability, ownership, and contribution flexibility are the reasons for the shift. And secondly, the employer's contribution levels in the HSA or the HRA tend to encourage employee participation and engagement. And when the employer is contributing toward these accounts, there's a sense of ownership and management that the employee gets that they don't quite get when they're participating in the standard HMO-style plan.
Okay, thank you. And I have a question here as well. What are some of the best mobile solutions available to payers today?
There is a proliferation of healthcare applications. One big caveat, and there are quite a few vendors that are developing these medical applications, let it be your fitness applications, or possibly from a payer perspective, finding the nearest doctor or identifying the location of a particular PCP and so on and so forth. One big caveat about before I can actually name an application or two, the topic of using mobile computing for medical, especially clinical related activities is subject to FDA review and regulation. FDA is clearly, and NIH is clearly concerned about the set of activities or amount of business activities and entrepreneurial activities, I should say, respect to mobility and mobile application. And it is becoming a concerning effect because the fact that the source of the information are yet to be verifiable, and accuracy could not be independently verified or approved for FDA or NIH. For those reasons above, I think we will see a set of regulations that are being introduced in the healthcare payer mobile application space. But the common names comes across that you can find, especially the traditional, for instance, Wellmark has a fantastic application that, I apologize, the WellCare. Hold on. One of those Walgreens, my apologies. Walgreens have introduced a mobile application that enables for things like prescription refills, the location, or even trivial information about a particular drug, complications and allergies and whatnot. So we're finding that a lot of consumer-driven organizations, once again, CVS, Walgreens, and also some of the health plans introducing their mobile application for better means of reaching the consumers.
Okay, thank you. And I'll just remind everyone to ask a question, just go ahead and post it into the chat box in the lower left-hand corner of your screen. And this looks like the last question I have at this time. What are some good starting places for healthcare payers to start defining consumerism in their organization?
I think that clearly the one good wealth source of data, Kaiser Foundation has conducted a series of surveys and statistical information. Clearly, that is one source of information for the value and the metrics around the activities or the adoption rate of consumerism within the healthcare payer space. I also do know that AHIP is quite engaged in that area. They have published many reports in respect to in the context of the healthcare reforms, the benefits and focus of consumerism, HSAs, HRAs, and related topics that touches that consumer-directed health plan notion, if you will. So I clearly urge the audience to visit those two sources. And traditionally, coming from a technology side, I will strongly urge you to reach out to Forresters and Gartners, your leading analyst firms. They have been conducting a series of studies around the technology components that are needed to implement successful consumerism initiatives.
Let me see if there are any other questions posted. We'll just give everyone a moment to post in any questions. I have a question again here from Rerum, what executive is most capable of pushing through consumerism at payers, CMO, IT, or other?
I think that pointing a single point to drive such enterprise effort, if you will, it may definitely have some short-term success. However, the enterprise adoption is the critical. So truly, the driving forces is the coming from the sales and accounting aspect to it, and to the operational aspect, because ultimate goal of consumerism not only providing product and services that are targeted and aimed to educating the consumers in general, but also being able to bend the cost at the payers, especially in light of recent MLR requirements that are being required by the Healthcare Reform Act. So clearly, it is a enterprise effort. It is a collaborative effort. I do think that the implementation should be done in agile steps, meaning that perhaps the foremost important aspect to it that you would like to be able to at least streamline one of or many of those mission critical applications. One area that we find that from a payer perspective that has been somewhat left behind is the new business underwriting and enrollment. It is clearly an area that's the customers or consumers' first level experience with a health plan. In the absence of appropriate technologies and an efficient processes to control and measure the end-to-end new business enrollment underwriting process, is perhaps that it could be the first part of or one of the first initiatives within the healthcare payer space as far as being ready and being able to interact with the consumerism. The second project or second phase of such effort could include the accounting and sales along with the customer service and support operations. As Jeff pointed out several times, that the importance of or the richness of the content along with context-driven delivery of that content to the consumers perhaps is the second most important aspect, being able to help the consumers making the informed, well-designed decisions that are suitable for that particular's need, individual's need. And subsequently, we think that payers actually could be very well, and this was one of the, in fact, I will say the Gartner prediction is that the payers will be forming these virtual organizations, channeling and interacting and dealing with the consumerism aspect, and henceforth possibly considering even outsourcing opportunities that from a sales and marketing perspective, from an enrollment perspective, from a billing and follow-up perspective, we are seeing that some payers actually choosing that route. In other words, they're really becoming almost a back office, a claims, operational, transactional. That's the core companies that we have seen. And we are seeing that some of the early adapters are simply expanding on that model as they take upon a new initiatives like consumerism. Because some cases that projects like initiative like consumerism is a culture change within the organization, not just a culture change for the consumers itself.
Great, thank you. And I have another question here. Many members are hesitant to engage with payers due to a lack of trust of the payers' motives. What tips do you have for payers to build trust with members?
I think this is a somewhat of a tricky question to answer, but truly the value that member must see throughout the experience that they have to have for a consumer-directed health plan to engage the consumer through their websites or through their products or documentations or channels, the reach-out programs that the plans may have, they need to take into account what the consumer's needs are. And this is one of the probably fundamental challenges in the context of the healthcare reform, this states-based, demographic-based consumer-directed health plans is perhaps the most difficult and troublesome part of the implementation or the policy itself. Demographic, understanding the consumer, understanding their needs is critical for payers. There are many ways that perhaps the consumers could be incentivized or enticed, better yet, to experience and use these tools. Clearly, once the dust settles about the FDA's regulation on the use of mobile computing, use of applications that are helpful for consumers to be able to keep track of their, quote-unquote, very much like their individuals' FICO scores that we all care about, our financial, the viewing, how it's being viewed by if we were about to make a major purchase. I think we're going to see initiatives driving health plans to be able to provide the tools and capabilities for consumers to better manage their health score, which in turn, perhaps a reduction in their fee schedule, and perhaps it ties into the MLR calculations. There are many, many ways I think we're going to see from the payer's perspective, finding and creating opportunities in engaging consumers so that view of mistrust could be slowly and gradually addressed.
Okay, let me just look and see if there are any other questions. Okay, I have a question here. What are your thoughts about recent reports or studies suggesting CDH plan savings are due to people simply avoiding needed care?
I can make a couple comments on that, Eugene.
Right.
Yes, I think that I did read a report on that, and that's certainly a trade-off, I think, in the marketplace that's occurring. And I also think that one of the keys is for folks to have adequate information to know what's the best choice for them, and that obviously delaying care can be dangerous, but it's not being able to afford any care at all that's probably even more dangerous. But yeah, that's something that I think really needs to be addressed and looked at, and figure out ways to deal with that as we go forward.
Okay, thank you, gentlemen, and it looks like we have taken all of our questions. So, thank you very much, gentlemen, for the great presentation and for sharing your thoughts today. And thank you to the audience for participating in today's conference. This concludes today's webinar. And thank you again for joining us, and please enjoy the rest of your day.